Right. So we see in chapter 22, there's a lot of pictures. So when we see that there's like 82 separate slides, right? Don't worry too much about it. There's about half of it are pictures like we see here. Now, let's take a look. Come back here. All right, about the bronchial tree. I think we left off with just right here with the bronchial tree, left and right bronchial, left and right main bronchus right here. All right. So as we go down, the bronchial tree is just a name that we give it of the actual bronchi as it kind of starts to separate, right, into secondary bronchi, to the tertiary, to eventually bronchioles, right? We call that whole system a bronchial tree. So when we look at the bronchial tree, again, on the right side, we have three secondary bronchi that is formed by the separation of the main primary bronchi on the right side. Right? Each of the secondary bronchi corresponds to the lobes. So if we have three secondary bronchi on the right, we have three lobes: superior, middle, inferior. On the left side, we have two secondaries corresponding with two lobes. The two lobes are superior and inferior. Now, the secondary bronchi are then going to split into numerous tertiary bronchi. Right? So on the right side, there's 10 tertiary. You're not going to need to know these numbers, and 8 on the left side. Again, right? They correspond with, the left side being having fewer, right, or less lung material. The bronchopulmonary segment, functionally independent units of lung tissue, right? We're going to see that this is what allows us to survive when we have a collapsed lung on one side, right? When we have a collapsed lung just on a specific area, right? Most people, even if one whole side of their lung is collapsed, right? Your left lung, right lung, the other side, there's enough airflow that can keep you alive until we can do some kind of a chest tube and put it in there. Now, all throughout the bronchial tree, we're going to see that it's lined with respiratory epithelium. Respiratory epithelium is ciliated pseudostratified columnar, right? Now, again, this should all make sense. The only two places where we don't have that epithelium is in areas where we can bring food in, right? Food might, if you think about you're eating fish, it could have bones in it and it can get stuck. Anybody's ever gotten a fish bone stuck in their throat? It feels like you're dying, right? You're like, oh my God, I'm going to bleed to death from this damn fishbone, right? So yeah, it hurts that much, right? And what happens is like, well, you need protection from something like that. So in the area we're introducing food and drink, we have that stratified squamous cells. In the other areas, we have respiratory epithelium, which is meant to trap, because we have lots of goblet cells, and then move that trapped inhaled particles of mucus upward so we can get rid of it. Now, we should also see that there's a lot of lymphoid tissue here, right? And lots of elastic tissue. Again, just to highlight that area about, make it easier for you guys to study what I expect you to know for each of the slides. Now, the mucosa right here is the area of the bronchi and bronchioles that makes contact with air, right? So if you think of the bronchioles and the bronchi as a tube, right? You have, in terms of bronchi, lots of cartilage forming the external part of the tube. And in the internal part, you have certain type of cells. The cells that are lining it are part of the mucosa. So if you ever looked into somebody's GI, pictures of their EGD for their stomach, right? Most people don't have bronchoscopy, so you're not going to see that unless there's an issue. But we do EGDs a lot, right? You can see that everything looks wet, right? They don't look dry. It just kind of looks wet and slippery. That's there for a reason. That's all those goblet cells that allows us to form a mucous membrane that covers either stratified squamous cells, so you have stratified squamous cells and then lots of mucus covering it, or respiratory epithelium and lots of mucus covering it. So the mucous membrane covers either one, right? Giving it the slippery look. The mucosa contains the respiratory epithelium. Those are the cells that are found there. And it's going to have something called the muscularis mucosa on it as well, right? Now, we're going to see this in the GI tract. So the muscularis mucosa contracts, relaxes to constrict or dilate the airway, regulating airflow, right? So this is important because we're going to see that this muscularis mucosa, remember, this is cartilage that we're going to see. So it shouldn't really constrict too much. It should stay open. So how do we cause spasms in it, allowing us to cough? Well, this is how, because we have the muscularis deeper layer, right, that causes us to cough. Now, one of the things we see in the bronchi is that, again, right, when we are going to bring blood from the heart to the lungs, right, we're going to see normally that arteries bring oxygenated blood away from the heart, right? Veins bring deoxygenated blood towards the heart. That's true everywhere else, except when we have blood flow to the lungs, right? It's weird because, in the rest of the body, all right, we bring oxygenated blood to the rest of our cells of our body through arteries. But that's not true in the heart, right? In the heart, when we bring blood that we need to oxygenate and we need to bring it to the lungs, we actually move through something called a pulmonary artery, right? And then we bring blood that's oxygenated back to the heart, right, from the lungs. We call it a pulmonary vein. So the names are switched, right, when we talk about blood flow to the lungs. So we'll talk about that in the afternoon. It'll make a little bit more sense, hopefully, then. The bronchial artery is the one that I highlight here for a reason. Bronchial artery allows for gas and nutrient exchange, right, for the cells that make up our bronchial tree. What do I mean? Right? You would think that since you're bringing air into the lung, right, that air that we're bringing in has a lot of oxygen. How come the cells that line it, that make up, right, that actual bronchial, how come it can't receive oxygen from the airflow coming in, right? The reason why is simple. That air coming in is coming in way too fast, right? You need time for air to kind of sit. As that air kind of sits, then the oxygen is able to diffuse through, right? If you're going fast through that, right, bronchial, what happens is, right, there's no time for oxygen to diffuse out of the air that you're inhaling into the cells. That air is moving too fast, right? So we need a separate artery to supply nutrients to the cells that actually make up our respiratory system. That's what the bronchial artery does. Right. Eventually, we're gonna have bronchioles, right? So we have tertiary bronchi, bless you, all right, and it's gonna turn into bronchioles. Bronchioles, and this is a big one, they lack cartilage, right? They're basically all smooth muscle. Here we have a change in cell type. And again, right, when we have a change, all right, there's a reason why I want us to know it. Is because whenever there's a change, right, now we're going to see that, right, we have a different cell type, we have a different component here. So what we're going to see again, right, in primary, secondary bronchi, tertiary bronchi, we see lots of cartilage, we see respiratory epithelium, right? Once we hit the bronchioles, right, bronchioles come out of the terminal, right? Come out of the tertiary bronchi. Now we not only have a change in cartilage to smooth muscle, but the actual cells change from pseudostratified columnar with cilia to ciliated cuboidal, right? Now, the big one is this, smooth muscle, right? When the bronchioles contract, they really start to contract and allow us to cough and eject air outwards, right? So when we have bronchiolar contraction, right, we can move air in and out, right? And we're going to see in a second why these smooth muscles are so important. And anybody has asthma at all? Right, good, right? The number of people with asthma is just exploding, right? The number of people in the city with asthma, right, is just exploding. It's been exploding since the 1980s, right? But why we have asthma is because of these bronchioles and the smooth muscles there. The smooth muscles that are going to, right, we have these tertiary bronchi made out of cartilage, contains that a little bit of mucosa that has muscle in it, all right? But usually that cartilage stays open, right? So usually when we have issues with not getting air into the lungs, like we do in asthma attacks, is not at the bronchi level, right? It's at the bronchiole level, right? What happens to the bronchiole level, because it's all made out of smooth muscle, when there's an issue and the smooth muscle closes, you can get air into like the bronchi, that's fine. But if you can't get it through the bronchioles, you can't get it into the cells that allows you to have gas exchange, the alveoli. All right, so all that air stuck in our upper respiratory tract. It can't get through where we can actually have gas exchange. All right, so what do we have to do? We have to give you something that will relax the smooth muscle, right? And that albuterol allows us to relax it, right? So we have about 50 to 80 terminal bronchioles. Terminal bronchioles are the big ones right here, the important ones, right? Each terminal bronchiole, even though you think it's terminal, right? That's the end. It's not, right? The weird thing is terminal bronchioles will connect to smaller respiratory bronchioles. And it's these respiratory bronchioles that are the most important part right here, because these respiratory bronchioles are going to funnel air, slow it down, and then move it to the cells that gas exchange occurs, right? And that is, right, now we're starting what we call the respiratory division. Up until now, every single part of the respiratory system we've mentioned, the primary, secondary, tertiary bronchi, the bronchioles, the terminal bronchioles, all of them's main job is just to move air and conduct it. That's it, right? Move it to a specific area. There's no gas exchange happening to any of these areas. Now that we hit the respiratory bronchioles, now we're going to see the respiratory division where gas exchange does occur, right? Now again, right, if there's a block here and now no block in the respiratory division or no block in the conducting division, we're still kind of screwed because remember, all we're doing up until this point is directing air here, right? As we direct air to these respiratory bronchioles, now we're going to see that the respiratory bronchioles have alveoli coming out of their walls. And because of it, it is part of the respiratory division of the respiratory tract, which is weird to say, right? So the respiratory division is where gas exchange occurs, right? It starts at the respiratory bronchioles. It continues in a lot more, right, surface area and volume at the alveolar sacs and the alveoli, right? So let me see, there's a picture here. Right here is a good picture. In this picture, you're going to see here is a, right, here's a terminal bronchiole, right? Here's a terminal bronchiole. Right? Terminal bronchioles, you think of the end, right? Because they're terminal. It's not. Right? I don't know why they name it this way, but it's not. Terminal bronchioles actually separate to 2 to 3 respiratory bronchioles. The respiratory bronchioles contains alveolar cells on them, right? Those alveolar cells are going to be where gas exchange occurs. Notice that you have capillaries here, right? Capillaries are where we slow down blood flow, right? Where the blood vessels here are very thinly walled, right? Just simple squamish cells, that's it, right? And because they're so thinly walled, they allow us to bring in a lot of nutrients and oxygen, right? So what happens? Air goes inside, right, through these terminal bronchioles. Air goes on the inside through the right respiratory bronchioles. As air gets funneled into the respiratory bronchioles, right, we have these cells called alveolar cells that are little tiny balloons. What happens when you put air into a tiny balloon? It opens it up, right? The more air, the more it opens up. As you open it up, what happens if you keep filling air into a balloon? Eventually it pops, right? Why? It's because you thin out the walls of that latex so much that eventually you can't maintain the integrity of that wall and it, all right, explodes out. Well, what we want to do here is get air in and then inflate it from the inside out. As you inflate it, right, you thin out the walls enough so then these cells that are forming the alveoli are spread thin. It allows oxygen to diffuse in and out really easily. It allows oxygen coming from the inside to go through the cells, all right? Because instead of being thick together, now they're kind of spread out. As they spread out, right? Now there's less surface area to go through, right? Oxygen just has to go through the thinly walled plasma membrane of cells that make up the alveoli. It goes through it, and what's on the other side? A capillary. They're ready to bring that oxygen that just came out. All right, now you can bring it into the blood vessel and into the red blood cells. Perfect, right? The more thinly walled everything is, the easier it is for oxygen to go through, right? And oxygen not to go through the cell, right? It has to go through the capillary cells. And now it can get into the bloodstream, right? Perfect. By the way, this is why pulmonary fibrosis is so devastating. In pulmonary fibrosis, we'll talk about some of these diseases later, right? You have fibers that are found in that area, right? Instead of just good cells. Now it's much harder to open up. And when they open up, now instead of just having, all right, opening up the cell and now you're kind of, kind of making sure that there's less surface area to go through, now you have fibers in the way, right? Oxygen can't get out of the cells into the capillaries easily at that point. They can, all right? Scleroderma is a little different, that you have a harder time opening the rib cage, right? That's pretty bad disease, right? So what we're going to look at here in terms of the alveoli, know the two types, and then this third type. We're talking about in terms of alveoli, right? There's type 1 and type 2, right? Type 1 cells, right, are the cells that are actually forming the alveoli. We call those, right, the simple squamous cells, we call them type 1 alveolar cells. Now, I'll show you, right, the picture is kind of simple, right? So you have these cells, the simple squamous cells, like this, right? They work together to form the alveoli, right? So oxygen and air goes in and it spreads these out, right? Spreads these cells out, so then there's less surface area for that oxygen to have to go through. We call these cells that make up the alveoli type 1 alveolar cells. And again, there's a reason why they're simple squamish, right? They're simple squamish for a reason. And that reason is simple, right? Because they're so thin, it allows gas exchange to occur almost like it's not there. Covers 95% of the alveolar surface, allows for gas exchange, right? The type 2 cells are equally as important, right? Great cells. These type 2 alveolar cells secrete pulmonary surfactant. Pulmonary surfactant, its main purpose is to decrease surface tension. Now, remember what I mentioned, that these are like very small balloons. Have you ever tried to blow open a small balloon or blow air into a small balloon? It's hard, isn't it? The smaller the balloon, the harder it is to put air into it, right? So if you have like a small balloon, what you have to do is really put in a lot of effort to open it a little bit. And once it opens up a little bit and you get a little bit of air in, it's much easier to blow it up the rest of the way. So that initial increase in size is the hardest part because there's so much surface tension. So what do we do to make it easier? We kind of like, all right, with the latex of the balloon, we kind of spread it out, we stretch it, right? And then we start blowing into it. Well, we can't do that in the lungs, right? Remember, it's like a small balloon. So with a small balloon, it's really hard to open it up right away. So how do we, right? If we can't open, stretch it mechanically, how does the body allow for easier opening of that balloon? Surfactant. Pulmonary surfactant is going to coat the outside of the cells and the inside, and it's going to decrease the surface area, making it slippery. So then it's easier for things to stretch out. How important is pulmonary surfactant? Right? You guys have heard that when premature babies are born, right, they're almost always have an immature lung, and they almost always have to be given, right, oxygen. The reason for it is, remember, right? One of the last things that develops in babies is the lung. The reason is you don't have to breathe in utero. So you're not really worried about the lung matter until later on in gestation. So one of the last things that does develop are these type 2 cells. So what happens when you have premature baby? Lungs aren't fully developed. You don't have type 2 cells. Hard to inflate the baby's lungs. All right. So in the old days, like in the 1940s and 50s, we gave them oxygen, right? Oxygen treatment to just inflate the lungs, right? We didn't have a man-made surfactant yet, right? And we'd have to use positive airflow with a lot of oxygen going into the lungs for them to actually, right, get oxygen exchange and survive. And what happened was that a lot of these babies actually started to get air emboli and they went blind from this when they recovered, right? So, and there was really no way for us kind of, treating it because we hadn't found a way of making human surfactant yet. Nowadays, we do have human surfactant, and now you don't see babies that are born preemies usually with any kind of sight problems, right? Because we don't have to give them that high atmospheric pressure, oxygen levels, right? We can give them normal oxygen, and with the surfactant, that's enough for us to bring air into the lungs. Now, the last type of cell are alveolar macrophages. They're the most numerous cell type in the lung, right? When we make a statement like that, right away, I want you to think, oh, that's got to be in the test, right? Because most numerous, right? Usually we don't like saying that kind of stuff. Pretty common, right? But most numerous, that's a very specific way of saying it, right? Now, with these alveolar macrophages, like all macrophages, their main purpose is to swallow things up and make sure it doesn't cause an issue, right? They're not foolproof, right? You guys have heard of tuberculosis, right? Anybody born outside the country? If you're born outside the country like I am, right, do you have a little scar on your arm? All right. Well, that scar, I got two scars, right? I'm old, so I used to have a scar from smallpox. Yeah, smallpox, right? And I have a scar from what we call the BCG vaccine. If you have a scar from the BCG, right, what they do is they give you a dead version of the tuberculosis bacterium, right? And hopefully it causes you to stimulate an immune response and to form specific memory cells. The problem is it's not very good, right? It does increase it somewhat, so then if you do get exposed, you don't get as sick, right? But it's not perfect. That's why we don't see it as part of the American vaccine system, right? The problem with the BCG vaccine is because we've been given that vaccine, we have activated macrophages, activated B and T cells from the previous exposure with the vaccine, right? Now, hopefully none of you guys are exposed to TB, but everybody will be exposed to the TB skin test. So if you're going to be in the health fields, you're going to need to do a TB skin test, right? What happens, right? For most people in America, they've never been exposed. They put the TB skin test with right, some of the, proteins from TB in there, right? And since you've never been exposed, you don't have cells that recognize all those proteins. Nothing happens, right? You have a very small induration. That's it, right? For someone like me that's had the BCG, when I was first given TB skin test, right, I had a lot of inflammation because I had cells already present that are there and it recognizes it. And they activate it, they think that it's an actual infection, and they try to fight it off, all right, causing this huge inflammation, right? But I was a like 20-year-old, so I didn't think anything of it, right? Took and they do give you antibiotics just to make sure, right? And the antibiotics are really strong, right? And they can cause your liver to have a lot of damage. So you have to be careful, right? So I don't think about it. I was in med school, and for the VA, I had to do a TB skin test again, right? They just do it to make sure you don't have TB, right? So you do a TB skin test, right? And I already had a previous large type of a reaction, right? So I should have known better, but I forgot because I was a young, stupid kid back when it happened, right? And now when the second time I was giving that TB skin test, right? Not only did I have vaccination before at the cells that I saved up, but I also was slightly infected with the first test, activating more cells. The second time they did a TB skin test on me, all right, it didn't just get inflamed, it turned black. All right. It turned black on me, right? It turned like I looked like I literally had a cigar burn, right? It got so bad that I was doing peds at, I was doing peds and parents are looking at me, right? In the middle of summer, right? They're looking like, covered up with a band-aid. And it doesn't look good when you have a big old band-aid on your arm, right? So eventually I had to wear like a real big turtleneck in the middle of summer just to cover it up. It took months for it to go away. So if you get a response, right, from that point on, you should not do any more TB skin tests. You can do x-rays, right? Now, why am I mentioning this with the alveolar macrophages? Simple, right? If you've been exposed to true TB, you inhaled it, it goes into your lungs first. Your macrophages will go around and try to swallow it up and kill it. But TB is Mycobacterium tuberculosis, very strong. It's a spore, right? And what happens is the macrophage can't get rid of it. And now you have these macrophages that are kind of infected with the TB. And we start walling off that area, right? And you start having necrosis in that area that's walled off that we can see on a chest x-ray. So if you've been exposed to the real TB, we do a chest x-ray, we know right away. You could have been exposed 15 years ago. You still have an area of your, lung that's walled off, right? That's consolidated, we call it, right? And we can see it on a chest x-ray. And from now on, I just do chest x-rays. I don't even let them try to stick me with another one, right? Is these macrophages, that's the main purpose, is to then swallow up any harmful bacterium, get rid of it. But with TB, it can't, right?
And you that can see that you.
It's clear,
Oh,
right?
okay.
It's clear. And since it's clear, then what, it was a false positive, right? It gives everybody that's been given that BCG vaccine will have all false positives, right? The only way we can tell if it's a false positive, though, is we do a chest x-ray. All right. Now let's talk about the alveoli. We should be done in a minute. Alveoli, each alveolus right here, surrounded by a basket of blood capillaries supplied by the pulmonary artery, right? The respiratory membrane is a barrier between alveolar air and blood, right? The respiratory membrane consists of, and I'm gonna highlight this area. Respiratory membrane consists of the cells that make up the alveoli, right? You have to go through the actual cells, the cells that make up your capillary, right? And then their basement membrane. That's it, right? So the plasma membrane of the alveolar cells, then a little bit of connective tissue, that's your basement membrane holding these two things together, and then the endothelial cells, which is also simple squamish, right? So we want very little kind of barrier between these cells so then gas exchange can occur really quickly. Right. So next, pleura, visceral parietal, right? Visceral pleura lines the outside of the lungs, very similar to the pia mater lining the brain, right? The visceral pleura, right, is going to be important. It actually makes the lung look really solid. Now, if you actually seen a picture of the lung, it looks solid, right? We'll see, models of it. It looks solid. If you ever gets a chance to touch the lung, right, it's very squishy, like a sponge, right? It's, that's a normal kind of consistency of a lung, right? So the visceral pleura is on the external aspect of all the alveoli. So you have all these alveoli forming the lung matter. And then you have this connective tissue called the visceral pleura covering it. Now, the parietal pleura lines the rib cage on the inside. Anybody's ever made ribs? Right? If you've ever eaten or made ribs, right? Any kind of ribs, right? When you make like lamb ribs, when you make pork ribs, when you make beef ribs, right? They always tell you to take that inner lining, right, of connective tissue out, right? And they say it's just connective tissue. What it really is a parietal pleura, right? And it covers each of the actual ribs on the inside. And what it does is it forms a seal, right? That seal of connective tissue, the parietal pleura, doesn't cook, right? So you need to remove it so then you can cook the meat from underneath easier, right? But we have it. We call it the parietal pleura. I know most people will freak out if we give it the real name. So we just call it a little, tissue, right? That's it, right? I mean, yeah, I understand, right? The pleural cavity, space between the pleura, contains a film of slippery pleural fluid, and it allows us to kind of form a seal, right? Functions of the parietal pleura: reduce friction, create pressure gradient. As your rib cage increases in size, it causes a drop in pressure, right? So then air wants to move into your lungs. That's a pressure gradient. I really don't understand why you even put this picture in, right? It doesn't show us where the parietal pleura really is, does it? Right? Versus ventilation is movement of air in and out, right? So when we think about ventilation, that is movement of air in and out of the lungs. That is expiration and inspiration. Now, what I want you to understand here is that there's quiet and forced, right? With quiet respiration, you're at rest, and usually your diaphragm is doing a lot of the work, all right? At about 8 to 10 breaths per minute, right? During exercise, we increase it from 8 to 10 to 30 to 35 right away, right? By the way, this is why I don't care how good of a shape you're in, right? You can be the best shape of your life. And what you're going to do is once you start jogging on the treadmill, the first 4 or 5 minutes, just horrible, right? They're so hard. You're like, I thought I am in good shape, right? And then what happens after 4 or 5 minutes? You catch your second wind, they call it, right? Now, what does that mean? Well, what it means is this: the first 4 or 5 minutes, the increase from 8 to 10 breaths per minute during quiet respiration to 30, 35 breaths per minute in forced respiration, that takes a lot of work, right? Before it's just your diaphragm moving things up and down, right? As a diaphragm contracts, your diaphragm is dome shaped. As it contracts, it pulls down. As it pulls down, your rib cage, all right, stays in place, but now you're having the pulling effect downwards. It causes your cavity size to increase, right? Allowing us to increase the shape of the lungs and the pressure drop right here. That's quiet inspiration. Quiet expiration is just a movement of the diaphragm back up, right? It doesn't really require anything else, right? Because it's just a diaphragm moving up, when we break it into thirds, if it takes 3 seconds to breathe, the first second is just for inspiration, right? It takes 2 seconds then to expirate. So it takes twice as long to expirate normally during quiet respiration, right? So what happens when you're working out? What's the easiest thing to do to increase your respiratory rate? Is to decrease the time for you to breathe out. So what happens, right? All your stomach starts to, abdominal muscle starts to work. So you force the diaphragm up more or quicker, right? Then your pec minor starts to work, forcing and depressing your rib cage quicker, right? Also, then you can expel air faster. As you expel air faster, you can take your next breath faster. So then you can increase your respiratory rate faster, right? So when we talk about pulmonary ventilation, is all about air pressure, right? We're not going to change the environmental air. That changes that, all right, that only changes when we travel. That's it. in Wisconsin, there's 1 atmosphere of pressure, right? That means that all the gases combined, oxygen, carbon dioxide, the big one's nitrogen, right? All of these exerts the pressure of us on us of 1 atmosphere, right? That's not going to change unless we go somewhere else. If we go to Denver, Mile High, there's less air, right? What happens? Well, there's less pressure from the gases. Instead of 1 atmosphere, you might be at 3/4 of an atmosphere, right? So it takes much deeper breaths for you to get air in, right? And it causes people to get into severe distress if they're not ready for it or they already have lung issues, right? So here, the only way we can affect any change in our, to get air in and out is to cause a change in our lung. As our lungs increase in size, it increases because it's being pulled by the parietal pleural. The parietal pleural is moving because of the rib cage being moved by your diaphragm, right? What happens? Everything increases in size, and as it increases in size, there's always a pressure drop. All right. Doesn't have to be a great amount of pressure. All I need is a little bit of negative pressure. And by increasing the size of the lungs, I create a little bit of negative pressure in the lungs. As there's a slightly negative pressure in the lungs, there's less pressure in the lungs than in the environment. What happens? Air goes from the air of higher pressure environment to the air of negative pressure in the lungs, right? That's how we breathe in. When we breathe out, right, you're forcing the diaphragm up, right? You're closing up the lungs with recoil, right? Causing a decrease in volume, right? Whenever there's a decrease in volume, there's an increase in pressure, right? We call that Boyle's law, right? There's an inverse relationship between pressure and volume, right? As there's a volume decrease in the lungs, there's a pressure increase. Air moves out then, right? The faster we have the ability to kind of change that shape in volume, all right, in volume, we can increase the pressure. So this is the reason why ever get tired from jogging and you feel like you have to, right, tripod, right? Why does tripoding feel so easy, right? Why do we have a child that's like 3 years old, right? They're running around like a madman. And when they get tired, what do? Right? They don't think about it. They haven't learned this at all. Why do they instinctively do that? Simple, right? Remember what I said, it takes more time to expirate than inspirate, right? So the problem is this, when you are breathing in and out fast and you're tired, right? You feel the urge to go into tripoding position because when you're in a tripoding position, what happens to my chest, right? Chest is much, right, smaller, right? Because I'm compressing it like this now. What else, right? When I'm compressing like this, right, the abdominal muscles can push in and can push up on the diaphragm faster as well, allowing us to expel air faster, right? Then we can inhale faster. The problem is you can't run around when you're doing it, all right? When you're tripoding, right? So if you're playing sports, your coaches are always yelling at you, right? Don't do that. Why? Is because you can't run around. So they want you to move your arms around there, lift your arms up, right? What that does is it allows you to take a deeper breaths. But remember, the problem isn't that you can't take deeper breath. The problem is you, all right, want to increase respiration rate. So it never feels comfortable doing that. All right. The diaphragm, prime mover of respiration. It flattens, enlarging the thoracic cavity, decreasing the pressure. I'm just going to write that down. Again, one of the things that it's kind of interesting in our body is that we do certain things physiologically and it looks like it's magic, right? In reality, we follow very similar laws that we see all around us. Laws of physics, laws of chemistry, right? One of them is this, right? Boyle's laws, fancy name for a law that just means that there's an inverse relationship between volume and pressure, right? The larger the volume of any holding tank is, right, the lower the pressure. right? I will use this example. If you have 10 gallons of helium gas and you put it in a 100-gallon tank, that's not a lot, all right? 10 gallons of that gas in a 100-gallon tank, all right? It's the same amount of gas if I put 10 gallons of helium and put it in a 10-gallon tank, right? We have the same amount of gas, but yet the pressure is different. When you open the spigot, it's different, right? Why? By putting that gas into a larger volume, right? You decrease the pressure. And that's what we see in our body as well. Oh, by the way, right? Everybody, when they first take a look at an X-ray, they always freak out. What the hell is this? Right? All right, so right here, let's take a look. This is your clavicle. You see how high up the apex sticks out? All right, here's your clavicle right here. All right, down here, you see the vertebrae. Up here, you see the trachea right here. Right? And if I take a look, it should be right down the middle. I don't know why it's got a little bit of a lateral deviation here, right? This is the cardiac silhouette right here, right? This cardiac silhouette, for anywhere where we want it to be about a third the size of your thorax, right? If the cardiac silhouette is really big and it's now half the size of the thorax, we think you have cardiomegaly or hypertrophic cardiomyopathy, right? Some kind of heart condition, right? That can be seen on a chest X-ray. Now, we should see black right here, black over here. Why? On a chest X-ray, there's a film behind me, and I have these, right, X-rays that goes through me, right? Anything that's solid deflects the X-ray. So any bone hits the X-ray, deflects off, right? That's why you see it in white, because it never has a chance to go through that area and cause the film to turn black, right? Because that's bone tissue, right? Anything that's not solid, right? Remember what I just mentioned, that your lungs are filled with air and they're squishy like a sponge, right? Any X-rays goes right through. As it goes right through, it hits the film behind it, turning that film black, right? Now, if I see any masses, it's going to also be solid. And I see a small white solid mass, right? Or God forbid, numerous white solid masses. So, right. So in terms of the accessory muscles of respiration, they're important for forced expiration, right? There's a lot of them. That's why I didn't highlight all of these. You have the erector spinae, sternocleidomastoid, pec minor, serratus, all increases volume, thoracic volume, all right? Normal quiet expiration achieved by elasticity of the lungs and recoil, right? Forced expiration, rectus abdominis, right? Internal intercostals, all increases abdominal pressure, increasing that movement of air out, right? Now, in terms of this, right, the rest of it, right? The neural controlled breathing, the one I want you to know is this very bottom one right here, the phrenic nerve, which we talked about, right? Remember, C3, C4, C5 keeps you alive, right? That's a term you're going to hear over and over again. The reason why is because C3, C4, and C5, branches of them will give rise to the phrenic nerve. Those branches then goes down and allows us to innervate the diaphragm. If you get damage above C5, you're going to not have a functional phrenic nerve and you won't move the diaphragm. That only happens when you have spinal cord trauma above C5. Now, the great news is this. If you had told me 30 years ago that we could stop and prevent spinal cord permanent damage, I would not have believed you, all right? There was a football player, right, for the Buffalo Bills, I believe in the early 2010s, right, 2013, 2014, right? First play, they kicked off, and this guy was, great athlete, went down. When he made a tackle, he had his head down, and he had spinal cord trauma at C4, right? And it was complete trauma. So, they were able to stabilize him, stabilize his neck. On his way to the hospital, he stopped breathing, right? Why? Because the phrenic nerve was severed as part of this. What saved his life, right, was that they intubated him. And then, right, by some luck of the draw, there was a neurologist at the actual, right, interventional neurologist that was actually watching the game as a fan, right, not part of the team, right? And he went to a actual symposium where they talk about doing hypothermic treatment for spinal cord trauma. And what they did, and he went into the actual ambulance with them, was they cooled his body temperature from 98.6 to 86 degrees. All right, that's pretty damn cold, right? 86 degrees, right? They give them cool liquid, cool saline. They put ice baths on them, right? Ice on them to cool his body temperature, right? And what it does cause, right, that cooling the body temperature, it causes less inflammatory cells to migrate to the source of that damage, right? What we found out is that that initial trauma is bad, but we can recover from it. What causes permanent trauma are inflammatory cells, our white blood cells, traveling to that area and in trying to help, causing more damage. So we can decrease the amount of white blood cells that travels there. Perfect. That's why we cool down the body temperature. It causes widespread vasoconstriction of the blood vessels. And the person was able to walk out of the hospital, right, a month later. Now, obviously, his football career is over, but he's able to walk out of the hospital and hold his babies, right, have a normal life, right, all because of that, right? That's it for this chapter. I'm not going to ask about, like oxygen transfer. That's a lot of physiology. I wish we have time to kind of discuss that, but we just, yeah, we have a few chapters to go through. So, all right, let's stop right here. Let's take a break. We're not done yet.